Hey, Paul. I've just written a song. It's about tortillas, actually. It's more of a rap.
That might be my favorite one you've ever done, actually.
Oh, well, that's unexpected.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Franquato, feeling really good about myself right now, joined here by Dr. Paul Nelson Williams, America's primary care physician. Paul, how are you doing?
I am well, Matt. How are you doing?
I'm doing well, and I should just mention that Paul being America's primary care physician, for that one listener who got really upset about it. Listen, man, it's just an honorary title. It's like if I had a coffee mug that said world's best dad. I mean, it doesn't mean I'm claiming I'm the world's best dad.
The joke here is that I think I am awful, and so this makes me deeply uncomfortable, and Matt knows that. So that's where this comes from.
Yeah. I'm basically, exactly. I'm bullying Paul. On tonight's show, we are going to discuss management, anticoagulation for venous thromboembolism. We have a fantastic guest, Dr. Tara Lech. And Paul, before we talk more about Tara and tell them about her, what we talk about in the episode, what is that we do on Curbsiders?
Sure, Matt. As a reminder, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. I should also mention, Matt, that this episode was written and produced by another one of our future bosses, a medical student, Ben Furman, who did an amazing job putting together cases and putting together a fantastic script. And the script is about the treatment of venous thromboembolism. And for that, we talked to the great Dr. Tara Lech. Dr. Lech is the director of anticoagulation services at Beth Israel Lahey Health, where she focuses on developing system-wide antithrombotic policies and creating an integrated stewardship program. She previously served as a cardiology clinical pharmacy specialist at both the MD Anderson Cancer Center and Lahey Hospital, and then spent 8 years as the manager of the Lahey Thrombosis Program. Dr. Lech's scholarly interests include antithrombotic stewardship, periprocedural management, and reversal strategies. She co-chairs the VascuLearn, great name, medical advisory board, and she received the Massachusetts Society of Health System Pharmacist of the Year Award in 2024. And Matt, in this episode, Dr. Lech teaches us all about managing anticoagulation, largely in the outpatient setting, though we do have a couple of sort of inpatient twists, sort of how we choose which agents to start with, what considerations, what the shared decision-making looks like, how long to treat for, and how to sort of think about nuanced and individualized treatment of venous thromboembolism.
And a reminder that this and most episodes are available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. Tara, thank you for joining us. We are really excited to talk anticoagulation with you. But before that, the audience demands that you tell them a hobby or interest that you have outside of medicine.
Oh, none. No, just kidding. I really like to travel and to do a lot of adventure. So I'm definitely not so much the relax on the beach, but like go to Greece and do a yoga retreat. Or this summer, I'm going with a friend to Italy for 2 weeks. We're going to hike the Alta Via one, hut to hut. So that's kind of what I like to do when I'm not in the clinic or seeing patients. In last summer, we actually took a trip to Amsterdam down through Germany, and we were one of those people that went to see, Taylor Swift in Europe. So we saw her in Munich, so it was pretty cool, and the Olympic Stadium. So hiked through the Black Forest on our way there. So anything that gets me out of the house, preferably out of the country, is a win.
You are living your best life. I'm very jealous.
And are you an avowed Swiftie, or was this just an excuse to be in Europe?
I mean, I'm, part of the tortured poets department, and just drink my coffee. So, yeah, I would say bona fide Swiftie.
Paul, you have that same mug. Hold it up. Come on.
People always assume I'm not a fan I don't know why, but I think she writes good songs. I don't know what to tell you. So. A question I like to ask is, can you share with us any meaningful advice or feedback, either that you've gotten or that you like to give people in the field?
Yeah, I mean, I think what really changed for me is when someone had kind of pulled me aside and I was young in my career, and I think you always want to be the best or show what you know, or, jump in on rounds, or, have the information. And I just remember one of my attendings letting me know, there is enough sun for everyone to shine. And I was like, okay. So I took that back and kind of thought about it. And then I realized, what I needed to do for myself was to, give other people room to grow, but also for myself to help myself grow. I had to look and identify mentors that were going to pull me into the light, right? And going to give me opportunities to learn from them, grow from them, and really kind of create this dynamic network of growth and opportunity. And ever since I shifted my mindset from, oh, what am I doing, but to what can we do together, it's kind of just propelled the trajectory of my career and opened up a lot of doors and opportunities. It's how I got connected with Anticoag Forum, which then, connected me with you guys. So, it's kind of been a win. But I just think it's important for the team to kind of win together.
Yeah, man, I'm trying to think of my evolutions in attending. I guess it didn't take all that long where I started to realize that when a student was really impressing me, that meant that the resident was doing a fantastic job. You know what I mean? You recognize that someone was actually smart enough to sort of polish their learner, and then you can sort of appreciate the entire team, and not just sort of it just took me a little while to actually get my head around the fact that that's it's not just a sign that the learner is doing great, but also that the person who's supervising them is also doing a great job too.
Yeah. Also good on your attending to that was a very clever way to give you constructive criticism. That's good.
Yeah. I took it to heart. Yeah. I know I think it is. It's nice to hear those things. And I like when people can be, honest with you and help you grow.
Yeah. Well, here we want you to just fully shine. Don't hold anything back on this podcast. And let's get into a case, Paul. Let's give her a chance.
Yeah, we're going to start with, this is an all-timer name. I'm really proud of our our producer for this episode. This is Ms. Reveraban. She is a 54-year-old woman. She's coming to our office. They passed medical history of type 2 diabetes that is well controlled on metformin. She has obesity with a body mass index of 33. She's presenting with left lower extremity pain and swelling that's been going on for about 3 days after she returned from a week-long international conference where she had to sit through a 10-hour flight and countless meetings. In the ER, her vitals look okay. Her blood pressure is 128/82. Her pulse is 84. Respiratory rate 16. Temp is fine. Oxygen saturation is good on room air. But a D-dimer is 640 nanograms per milliliter, and an ultrasound examination was performed that showed an isolated thrombus in the left popliteal vein. So let's just start super broad. I'd like to hear just sort of your general approach as you're thinking about someone who's just been diagnosed with the DVT, and then we can sort of narrow down to the specifics of this case.
Yeah, I mean, it sounds like a pretty straightforward clot. She likely had some transient risk factors with that long flight. She came in, presenting with signs of the blood clot, and now thankfully she's stable. So we need to start thinking about getting her on an anticoagulant as fast as possible. So we're going to, hopefully run a few tests, rule a few things out, make sure she, would be a good candidate for potentially a DOAC. Probably one of the more important tests we have to run is the test of insurance, unfortunately, to kind of help drive that decision. But then, once we start to get some more information back, looking at her renal function, her liver function, other medications she might be on, then we can start to think about what is going to be our potential first line of therapy.
Yeah, you mentioned renal function. I think this has evolved over time, because I was looking back to, I think 2019, when we were talking with Dr. Strife about anticoagulation for VTE, and he was talking about how Edoxaban at the time, they were some people with renal problems were using it at a lower dose, and some people were using it at the regular dose, and then Reveraban, I think, wasn't really studied at lower. So where are we at now with those and renal failure? Because that's just a common thing, or just people with advanced CKD, like EGFR less than 30.
Yeah, I think the evidence is really kind of evolved in that space. We're seeing a lot more patients that fit that demographic, and we really try not to exclude them from DOACs whenever possible. We look at, where their creatinine clearance is falling. Is it in that, 30 to 50 range, 15 to 30, or, are we looking at true renal failure, potential dialysis patient? And that kind of, starts to whittle down our options. I think the two DOACs that we think about most are, Reveraban or Apixaban. And when patients do have that lower creatinine clearance, like less than, 50, less than 30, I think people are tending to go more with Apixaban as first-line therapy. We are seeing a lot of data where we've looked at patients in that patient population, and compared to warfarin, retrospectively, it's at least as safe and as effective without the monitoring and kind of the burden that warfarin carries along with it. So for those patients, I think DOAC is on the table, but I think one thing that you touched on that I think is important to highlight is that when you are treating VTE, there is no dose reduction. So you have to commit. You have to go all in with these patients. If you're starting with Apixaban, they're getting that 10 milligrams twice a day for 7 days. And then they're going to stay on the 5 milligrams twice daily for at least 3 to 6 months, depending on the course of their treatment.
Yeah, and does this differ? Because like with AFib, I think it may be a little different. At least for Apixaban, they have that criteria, age and weight, and I can't remember the other, creatinine, I think.
Yeah.
Yeah, the AFib patient population, you can dose reduce. So like in the dialysis patient population, they're always going to have one for serum creatinine. And then you look at their, weight, if they're low body weight or advanced age, then you'd think about the 2.5 twice daily. Otherwise, the package insert labeling would tell you to just use the standard dosing. I think this is still a gray zone, though, where it's evolving. Just using anticoagulation in dialysis for AFib patients, risk-benefit, I think is still questionable. Yeah. But for VTE, we know the benefit is there, and we want to treat them maximally.
Yeah. So that's for Apixaban. So there's no reduced dose at this point for venous thromboembolism. We're just kind of, if we decide we're going to use it, we just go full out. And what about Reveraban in that population?
I think there's still a little hesitance, like if patients' creatinine clearance is less than 30, especially, because you're going to have to start with the 15 twice daily and then stay on the 20 milligrams daily for an extended period of time.
Okay.
And there's not as much data with the, low to very low creatinine clearance, less than 30.
Yeah. So how does this discussion go when you're talking to a patient about it? Like the initial choice?
So with the initial choice, we try to be, clear with the patient's preference, making sure the medication is affordable to them, and trying to keep things as simple as possible for the patient. I think especially in the initial period, they have a lot going on. Especially if this is their first blood clot, they're trying to wrap their head around what happened. They're thinking about extension or recurrence, or how this is going to impact their life long term, what this is going to mean, for them now and in the future. So I think when we're talking to them about medications, it's more so trying to think about their lifestyle, their preference. Is this looking like someone that can continue to take a twice a day medication, or is once a day going to be preferable for them? And then really just making sure in that moment, whichever agent you're choosing, if it's Apixaban or Reveraban, that they get, as a pharmacist, I like to say, know your meds. And meds would be the acronym for like your medication. Do you know why you're taking it? And do you know that it's available for you to pick up when you leave here, or are you going to leave with your drug? The E would be education. And in the initial phase, we're talking about bare minimum, because we're going to come back and we're going to educate them, in a few days to weeks to months to keep re-engaging the patient. So at the bare minimum, I want to make sure that they understand why they're on this medication and how to take it. If there's any nuances, like, with the Reveraban, making sure they know they have to take it with food, all the key essentials, and then major adverse effects that they should be looking out for. So, any kind of symptoms or signs of bleeding that they'd want to report back right away. The D would be, do you understand? And do you know who to call if you have a problem once you leave the emergency room or the PCP's office? And then S, like, do you have a schedule? So do you have a follow-up with someone, and do you know why it's important that you go see them? So if they can kind of check those boxes, then we can get them out the door. And then we know that we have to follow up with them. But the biggest thing is, making sure that they understand they need that medication today. If they're in an ED that cannot dispense a starter pack or cannot leave them with some doses, we still have a lot of patients that end up going to the pharmacy and they don't have it. They say, I have to order the starter pack. And the patient just says, okay, let me know when I can come back. And so when patients get enrolled into, my clinic or some of the other anticoagulation clinics out there, we're doing that follow-up call within 24 hours in most cases. And we still find a fair amount of patients that we have to scramble to get drug in hand.
Wow. So they're getting diagnosed at the primary care or the emergency, and they're ordering the drug, and then, luckily they're getting in with your clinic who's checking within 24 hours, because otherwise it could have been who knows how long before they actually got drug in hand.
Yeah, it's crazy. And you'd like to think it doesn't happen. Or, even for me, I would like to think like the pharmacist would say like, oh, I can't let you leave. Let me call another store. But, I know they're busy and there's a lot going on. So there's a lot of places where things can fall through the gap.
Mm-hmm.
The M for meds part, I'm especially curious about. So, are there any particular medications that you're looking for every single time that are common that we should be mindful of? And I guess, what are the non-starters, and what does the counseling around sort of common medications look like? I obviously won't ask you to go through all the meds, but like the big ticket stuff, like counseling around NSAIDs or that kind of thing. Like, I guess, what does that look like at the initial visit, and how does that sort of sway which medication you might choose?
Yeah, I'm always screening for unnecessary medications like NSAIDs or aspirin if it's used for primary prevention, or if they, had been using it, in dual therapy. Can I drop, the aspirin, leave them on just a thienopyridine like clopidogrel or ticagrelor? NSAIDs, I'm counseling them, just because it's there doesn't mean they're taking it. So it's always good to have a conversation with the patient, ask them how often they're taking it, what they take it for, and see if we can find them some alternatives like, acetaminophen for their pain. And then going through to make sure there's no major drug interactions. I think that's one of the nice things with the DOACs is that there are far fewer, but the ones that are there are significant. So when we have those strong inducers, inhibitors, you see things like carbamazepine or ketoconazole or rifampin, those are kind of non-starters. And so then we usually have to take the DOAC off the table, and in those cases, think about a bridge to warfarin.
I wanted to ask about with this initial choice here, we talked about Reveraban and Apixaban. They're both 10A inhibitors. Debigatran was the first one. Way back when Paul and I were in residency, it was like the new one around, the first one around, I believe, at least in our hospital, and it was very expensive. It seemed like quickly people stopped using it. Can you talk a little bit about why that's not used as much as the others?
Yeah. So, when it first came out, Debigatran was the primary studies were for AFib, and they actually had good results for AFib. It was, and it still is really the only DOAC in trials that had a significantly lower risk of ischemic stroke for AFib patients, but that got outweighed by the GI bleed and dyspepsia. So that kind of took it out of the spotlight. And then once the other, Reveraban and Apixaban came to market, they kind of took over because patients were not having to worry about how they stored it. The Debigatran capsules are very sensitive, so you have to store them in their original container. They're not good past like 60 days. And yeah, they're dyspepsia. And it is, we see more GI bleeds with Debigatran. So there's less favor there. And then when they went to study it in VTE, both Debigatran and Edoxaban actually used a 5 to 10 day lead-in period with a low molecular weight heparin. So monotherapy with either enoxaparin or heparin for 5 to 10 days. And then you could switch to the DOAC. And so for, most patients, most providers, that's not ideal. I want you to leave with the drug you're going to stay on. And so for VTE, that's why it's very infrequent, if ever, that you really see it as like first line therapy.
That is a great explanation. Yeah, I didn't know. I remember vaguely the dyspepsia thing, but I didn't realize that whole history there. So the 5 to 10 day lead-in with a parenteral agent, can you talk about that? And is that why we have the loading doses with the Apixaban and Reveraban? Can you talk about what are they doing with those? I've heard maybe some different explanations. Are they just trying to get them therapeutic quicker, or is it because there's a higher risk of recurrent clot or just pulmonary embolism in that first that short time there? So you want them to be like much more aggressively anticoagulated, but I don't know. Do we know this now?
I think there's been a lot of discussion, and a lot of those points will come up. I mean, what we do know is that in the first few weeks, the risk of recurrence is highest. And when it was studied, either with Apixaban with that 7-day lead-in of the 10 BID, or Reveraban with the 21 lead-in of 15 BID, it was well tolerated with patients, low rates of bleeding, and you don't see a lot of recurrence in those first few weeks with those regimens.
Okay, so we're probably just stuck with that. It sounds like that's probably not going to go away. It's just going to be there.
It just leads to the debate too. I mean, this case is nice because you can probably treat it outpatient and they're going to go home. But then always comes the question, if someone were to be admitted, do you subtract days or do you send home? I think that is a gray zone, and depends on who you ask. And more so depends on the bleeding risk of the patient and kind of how you're going to approach.
Okay.
That
yeah.
piece
So
of care.
let's ask you then. We want your expert opinion on this, right, Paul?
Yes, that's what we're here for.
Like, let's say a person happens to be in the hospital with DVT-PE, and they're in the hospital for 4 days. So, and they took Apixaban or Reveraban. Would you subtract days, or would you just give them the full starter kit on top of that?
So, I mean, if they had a DVT and a PE and they had, fairly low risk of bleed, I'd probably just give them the starter pack. Another thing too is, ease of dosing. If we're subtracting, now I have to make sure the patient knows to either subtract from the starter pack, or I have to do the math to get the number of 5 milligram tabs to equal the 3 days of, 10 BID and then the 5 BID. I think it's more so when it's those high bleeding risk patients that have had, very complicated stay. Maybe they've needed some mechanical circulatory support and they're days, week into their course. Then you may be, thinking more along the lines of, okay, well, they've done 5 to 10 days of parenteral therapy and starting the, maintenance dose of therapy at that point in time. But definitely a case-by-case basis.
Yep. And that explains why I don't know that I've seen Edoxaban much in the wild. That might be a U.S. thing. Paul, have you?
I have not seen that in the wild. No.
Right. Okay. So I guess I wonder if they'll ever just try to find a starter dose for those meds so that it kind of takes away this barrier with this 5 to 10 days of parenteral. But maybe it's too late now. They're not going to run giant clinical trials again.
Yeah, I think it's kind of out the gate for them. I think Edoxaban, they were hoping more so they would see its place in cancer-associated thrombosis. But when the other DOAC started to study in that space, and they found similar efficacy with Apixaban and Reveraban, which more people are already, very comfortable with, they tended to just stay with what they know.
Mm-hmm. All right. So we have some things to look out for here. You told us, so Apixaban, Reveraban, why they're most commonly used. We just went through that. We talked about the drug interactions are much less than warfarin or the vitamin K antagonist, but carbamazepine is one to look out for. I guess if someone's being treated for latent tuberculosis with rifampin for for 4 months, that might be an issue.
It's like half my patients, Matt.
You know what? The smartest thing I did was I just hired a pharmacist on our team, and he previously was doing antimicrobial stewardship, and now he's with us doing anticoag stewardship. And so he actually looks at these cases and then calls ID and says, actually, you don't need rifampin. You could use, this other substitute. And then he keeps the patient on the DOAC. And I am a big fan of that. So we have a crossover, and it is working really well.
They must love that. Whoever's in that quagmire, they must love someone calls them and gives them great advice like that.
I'm kind of surprised we haven't made it to this point already on the episode, Matt, where I think every time that we have a pharmacist on, we're just, thank God that you all exist. Like it feels, it's like a security blanket whenever I have a clinical pharmacist that works something like that. And every time I walk past her, I'm just like, oh, thank God she's here. Like I don't know what I would do without our pharmacy colleagues. God bless.
Yeah. And this is not pandering. This is just straight up
It's
truth.
legit.
Like in every hospital, the teams that round with the pharmacists for like anticoagulation or ID, you're always jealous of them because you learn a lot, and it's just like you're able to very well take care of people when you have that kind of knowledge just like right there. It works well. So we appreciate all you pharmacists. We do have pharmacists in our audience, and we appreciate them. Paul, what do you want to talk about next? I know, so we're still talking about Miss Reveraban.
Thank you. Yeah, I wanted to bring it back to Ms. Roxaban. So just a reminder, since it's been a second, that this is our 54-year-old woman with diabetes and obesity who has DVT after a long flight and a lot of sitting around at conferences. So something I'm looking forward to shortly. I would like to know, in this particular case, and then sort of more broadly, like what does treatment duration look like? Like how are we thinking about how long to treat this person for? Because I feel like that's always kind of a moving target too, in addition to all the other stuff that we've talked about.
Yeah, I mean, I think from the time of your 2019 podcast to now, I think people have really started to focus more on what are the risk factors that the patient has. Are they transient? Are they permanent? Are they major? Are they minor? So, in this case where she has a transient risk factor, where she's had the long travel, that would typically be considered a minor transient risk factor. So, she could potentially just do her 3-month course of treatment and be done. If that's, she's done with her conferences and travel life, if this is something that's going to continue for her, then we have to keep, having the conversation and whether it's, travel or surgery or estrogen therapy, trauma, whatever it might be. I think it's just important to know that if they are the transient risk factors and you do decide to, stop anticoagulation after having, a conversation with your patient, we always want to include them and make sure we understand their goals of therapy as well. That we have to continue to engage them throughout the course of their, progression, because even though we stop anticoagulation, the event has resolved, their risk of recurrence never goes back to zero. So, if any of these provoking factors come back again, or we know that they're going to be going on, long flights or, having trauma, having surgery or, starting contraception, then we need to revisit these conversations again.
You mentioned the flight thing, and I think it was the ASH guidelines they actually mentioned long distance travel in them, and it seems like there's still some differing opinions there, and the evidence quality is very low. We had Dr. Jean Connors on, and she said sometimes if it's someone who has a history of unprovoked clot that is going to be going on a very long flight, and they for whatever reason this person is not taking long-term extended anticoagulation, she might put them on for the duration of the flight. What are you seeing done in what are we calling the forum?
The AC forum?
Yeah, the AC forum. Yeah. Okay. I want to sound cool when I talk about it. Okay. So the AC forum, what are people saying there about this? Is that what's the latest?
Yeah, I mean, I don't think it's a one-size-fits-all. It's funny because I update the literature library for the Anticoag forum. So every 2 weeks, we go through all of the Anticoag-related resources that come out and then put them on our website. And just a couple months ago, there was a paper that was, on the fright of long-haul flights. So, I had checked it out because I get a lot of mixed opinions on this. Some people will, say it's fine to, stretch, stand up, do some, exercises, make sure you're hydrated. But in cases where people have had, a thrombus in the setting of a long flight, it isn't wrong to consider it for these patients. I mean, they're going to be potentially immobile for a long period of time. They're apt to get dehydrated, the pressure changes in the cabin. There's a lot of stasis going on during the course of that. So giving them some prophylactic anticoagulant to get them through that is definitely something to consider. Another thing we think about too is like, where are they going? Like if they were to go on a long haul flight and then get off and have a clot, are they going to be somewhere where they are going to have the same access to healthcare. So maybe they've already shown you that they could tolerate anticoagulation. They've been treated for, at least 3 months. So you're going to give them a prophylactic dose for, a day or two for the flight. In coming back, it might save some serious complications at their destination.
So just to get granular, for Apixaban or Reveraban, what dose would you prescribe?
Yeah, so for Apixaban, it's the 2.5 BID, and for Reveraban, it's the 10 milligrams daily.
Okay. And I think it was the chest guidelines somewhere buried in there. They say frequent ambulation, calf muscle exercises, sit in an aisle seat if feasible, and then you might wear compression socks.
Put on your stockings, yeah.
So those are other things that people talk about.
That is demented. Get out of here.
You don't like an aisle seat, Paul? Are you kidding me?
No, I'll sacrifice legroom for a window seat.
Okay, Paul, I don't know. I'm going to say this to the audience. I've traveled with Paul a fair amount. Guy will not drink anything for 3 hours before the flight. He's got Paul, I'm going to run some labs on you next time we get off a flight. That's why you don't sit in the aisle. I bring a gallon of water on the flight. I sit in the aisle and I use the bathroom whenever I want. It's great,
no,
Paul.
I'm a camel or a kangaroo rat once you put me on an airplane. I'm not getting in the bathroom.
Well, all right, Paul. We
That's
like
more than our audience
we like
needs
to
to know,
travel
actually.
differently. All right, Paul, I totally lost what we're talking about here. Well, long distance travel. That's right.
Yes.
All right. So we've decided maybe we'll give them the prophylactic dose of Apixaban or Reveraban. If you want to do the Paul method and not move for 4 hours on a flight, that's fine. I would recommend maybe some stockings, calf muscle pumps, and an aisle seat. Or is that where we're at, Paul?
That's where you're at for sure. And this all stemmed from sort of the duration question, I guess. I don't know. As we're sort of mixing up the ingredients here, if we could sort of spin the wheel and change the scenario a little bit. It's just having looked at the guidelines and Dr. UpToDate, whom I trust in all things, recently on distal DVTs. What are we doing for them? Because I found it a little bit bewildering in terms of the discussion of asymptomatic and low risk. And you can do serial ultrasonography in certain select cases, but I couldn't imagine a world where that patient existed. So as our expert here for the distal DVTs, how differently are they treated than the ones that are above the knee?
So again, it's hard to say because normally we don't go looking. A patient has symptoms, whether, it's the swelling of the leg, the erythema, and they get a scan and we end up usually treating them, for a short period of time. If someone really, it's their preference to not be on anticoagulation and the symptoms are very mild, there's not a lot of extension, then, we may repeat the scan and have them come back. But I've tended to see more patients opt on the side of treatment than not because of the fear of extension.
I think I've seen maybe one person, and it was some extenuating circumstance where they were getting weekly scans, and it was tough to set them up. I think we intended to get weekly, and they end up getting one 2 weeks later. But it doesn't come up. It comes up often that you find a distal DVT for whatever reason, but it doesn't come up too often that someone doesn't just say, okay, fine, I'll just take anticoagulation for 3 months or whatever it is. Yeah. So I guess for the duration, just to kind of put that to rest. So they give some guidance that it's leeway, 3 to 6 months. And you said basically it's was it a transient risk factor or a permanent risk factor? Or was it major or minor? So I'm guessing somebody with a bad cancer that's not going to get cured and they have a clot, that's a major permanent risk factor versus somebody that went on a 6-hour car trip and had a distal DVT, that's kind of the minor transient, and maybe we'll do 3 months for them. Yeah.
With the car example, that's when you're kind of debating, right? You're talking to the patient. You're like, this could have done it. I don't know. Did you really not get out of the car? Did you not stretch?
Mm-hmm.
And so you can kind of get away with it. But when they have the active cancers, antiphospholipid antibody syndrome, or have had a recurrent event, then that kind of just takes the duration out of the equation. We're most likely looking at indefinite, or at least as long as the cancer is active.
Do you also factor in clot burden if they had really extensive lower extremity clots, or if they had a larger pulmonary embolism? embolism, is that something that you also factor in to duration?
I mean, I think a lot of it does more so come down to the risk factors, but if someone, was about to code or did code, then the threshold, I think, to keep them on indefinite is very low. And it's just more so being honest with the patient, talking to them and making sure they understand, the goals of care, the benefits of staying on anticoagulation long-term, and then the risks. And then I think more so you start to get into, do I feel comfortable, with extended prophylaxis and kind of dose reducing at that 6-month mark, or am I going to keep them on full dose therapeutic? And that might be where you're looking at clot burden, residual symptoms, any kind of, progression or recurrence would make you maybe err on the not dose reducing patients. But
Yeah. Okay. That's helpful. Thank you. Paul, so let's do some variations here. So for Miss Reveraban, if she was a bit younger and she was someone who was, pregnancy was potentially in the mix and she was going to need to be on anticoagulation, how does that factor into the conversation?
So it kind of takes a lot of the agents off the table. So we try to, if someone's already been on anticoagulation, if they're on a DOAC or they're on warfarin and they're of childbearing age, we do try to have routine conversations with the patient to say, you need to let us know if you're, planning to conceive, or as soon as you get your first positive pregnancy test, you need to let somebody know right away so that we can switch you. If we do know that someone is actively trying to conceive or maybe going through, IVF or, some other modality, then we may just upfront switch them from their DOAC or warfarin to a low molecular weight heparin, which would be, considered safe during that time period. But we would want to get them off of their DOAC or warfarin as soon as possible if they were to become pregnant.
Yeah, I always get, I don't know, Paul, about you, but I always get nervous when any of my patients are pregnant or planning to become pregnant. I'm just like looking up medications like crazy, asking for opinions, because sometimes you don't have super strong guidance. So it makes me nervous.
And God help you if you're breastfeeding. It is a nightmare. Again, for the pharmacist who works with me, she knows when she sees me coming, that's probably the question I'll be asking about.
And we talked about cancer a little bit. So you said initially Edoxaban was the DOAC that was first kind of going after that cancer indication, but now it seems like this is a class effect. We just sort of say any DOAC is for a VTE in someone who has cancer is okay.
Yeah, pretty much anything except warfarin is okay for the cancer patient population. Gold standard used to be the low molecular weight heparins, but now all of the DOACs have really showed that they're similar efficacy and, similar safety. I think with Edoxaban, it was more so to a composite endpoint. So there was a little bit more bleeding, especially with GI cancers. So you have to be careful there. It's the type of cancer matters for your patients. There's a lot more data in solid tumors versus liquid tumors. And then, the thought was actually, this is perfect timing with ACC just wrapping up. But I think historically, we've always kept our cancer patients on full dose therapeutic anticoagulation indefinitely. But now there was this trial that it actually just came out a couple days ago over the weekend, APICAT. And so they looked at extended prophylaxis with Apixaban in cancer patients. And this is, I think we're going to be doing a journal club on it in our clinic very soon, but I think this is going to be practice changing, where we're seeing now that the Apixaban at least is as safe and effective at the extended prophylaxis, so the 2.5 twice daily dose, as the 5 BID, but potentially less bleeding, which is, very important for when I think about our cancer patients. I'm always thinking about quality of life and bleeding complications. I feel they're very close to my heart. Actually, my first job out of residency was at MD Anderson Cancer Center. So I was the cardiac pharmacist there. And I was actually working there when DOACs came to market. So that was a game changer even to begin with. It was all we had was low molecular weight heparin and warfarin for the poor patients that could not tolerate or would not stay on the low molecular weight heparin. But now with the DOACs, it's just been such an improvement in their quality of life. And now if we can, potentially use this extended prophylaxis therapy and minimize bleed risk for them in the long term, that's a big win.
Yeah, I saw one person on Blue Sky who was very angry about the study, but I have not had a chance to dig into it to figure out what they were all excited about. But I'll circle back. That might be something for hotcakes later on, Matt.
Yeah, it sounds like it. If they were angry about it, it sounds like some skeptical person maybe. That's good to know. I wanted to ask the pharmacology of Apixaban versus Reveraban versus Edoxaban. Is there a theory as to why Apixaban seems to come out like better than the others in some cases, or certainly for bleeding risk? It seems like that's been pretty consistent. And I think I read Reveraban, and I can't remember. I know you just said one of them, but was it Reveraban or Edoxaban that has the increased risk of bleeding with GI cancers? I thought it was Reveraban.
And Reveraban too. So I think they both have showed that, in those GI tumors, we have to be very cautious with those medications.
Okay.
It is interesting that they're both the once a day DOAC. So I don't know if it's something to do with the higher peaks compared to the Apixaban. Looking back at some of the dose finding studies, they kind of try a lot of everything and see what sticks. So potentially, maybe depending on the patient population, the once daily 20 milligram dose of Reveraban may have quite a bit of a higher peak compared to Apixaban twice daily. So I think it's just more so talking to the patient with a shared decision making and making sure that the drug is right for the patient. Another thing you have to consider too is, you have to take the medication with food if it's Reveraban. So sometimes our cancer patients are having poor appetite or maybe experiencing nausea, vomiting, depending if they're getting active treatment. So that may not always be the best option for them either.
Yeah, and it's weird that I was looking up on Lexicomp the half-life, and it looks like Apixaban has a half-life, it said 12 hours, and Reveraban's half-life, depending on if it's an adult, is like 5 to 9 hours. If they're older, it might be 11 to 13 hours. So it just seems like, it's weird that it seems like Reveraban for some people has a shorter half-life than Apixaban, but it's only dosed once a day. That just doesn't make sense to me.
No, and it's interesting because, when I talk to, some of the healthcare providers, that is something that I think it's hard to wrap your head around. And so when they're thinking of the science and the PK/PD and half-lives and clearance, that kind of makes sense. I think another reason people lean to it too is that Apixaban has the lowest rate of renal clearance. So, it's like 25% cleared by the kidneys as opposed to like 33% with Reveraban and higher with Edoxaban, and Debigatran's like 80% renally cleared. So it's like as patients advance in age, that's another thing to think about as well, and not having to rely as much on the kidneys to get rid of the drug.
Okay. Yeah, well, I guess mystery solved, Paul. That's... Okay, so how should we wrap up this case? What are we going to put Miss Reveraban on? Should we give her Reveraban, Paul, or should we put her on Apixaban?
No, I think being contrarians, we should give her Apixaban, and she does great.
Yeah. Okay, so she's going to go she does the 10 milligrams twice a day for 7 days, and then she goes on the 5 milligrams twice a day, and we decide we're feeling... We're like, oh, maybe this is a transient minor risk factor, Paul. So we only give her 3 months because she's worried about bleeding and she just wants to get off it as soon as possible. So that's what we do. Does that sound okay to you, Tara?
I think I'm good with that.
All right.
It's a really rich backstory you've created. I'm really impressed, Matt.
On the fly too, Paul.
All right, let's shift gears. We're going to talk about Mr. Occlusion, a 51-year-old gentleman with a past medical history of high blood pressure on amlodipine, a remote history of tobacco use, 15-pack years. He quit 10 years ago. He leads an active lifestyle. He works outdoors. He exercises routinely. He's coming into his primary care doctor's office after noticing several days of progressive swelling, erythema, and tenderness in his right calf. He denies any recent histories of surgery, trauma. He's not been immobile, no recent trips, no long travel. Afebrile, vital signs look fine on examination. On exam, he does have unilateral right lower extremity edema, warmth, erythema. Oh, in the case we checked a Homan sign, but which we probably wouldn't actually do, I don't think. I think, Matt, remind me if I'm wrong, I believe Homan has said, please don't do my sign. Like, I think even he has been like, you should not be doing that.
I haven't read that, but I think you or somebody has mentioned it on the show. It's one of those things in medicine that just like, everyone loves to do it and talk about it, but yeah, it's like Koenigs and Brzezinski, right? Those are also similarly like not sensitive and specific enough.
You see also like 90% of our physical examination, unfortunately, like Tennell's, Fallon's, tuning fork tests, all of it. Anyway, sorry, I took it down that side, Beth. But anyway, looks like the guy's got a DVT is what we're saying here, Matt. And we do compression ultrasonography. It shows a right-sided femoral popliteal DVT. So, Tara, in this case, this is a little bit different than our first case because we've taken an excellent history, as is our way, but not really found any good reason for this person to have a DVT. So this seems like it's unprovoked unless we turn up something else further in the history. So how does this being ostensibly unprovoked change, I guess, how you think about it, what agents you would choose, and sort of how you would start thinking about Mr. Occlusion?
So I think the good news is up front, things are pretty much the same because everyone's going to get an initial 3 months of treatment at least. And then we're going to, be having them come back. And, in this case, we're probably going to say, you're going to stay on for at least probably another 3 months. And then at the 6-month mark, could talk about either continuing the dose or, giving the extended prophylaxis. But, these cases where we can't really put our finger on what the risk factor is, it's hard to think about stopping because, the odds of recurrence are higher in this case. So we would, assess, see if we can rule anything out. But if we don't see anything major, then we would likely do indefinite treatment and, factor in, of course, like the assessment of bleeding. And, we can also kind of go through the assessment too of just risk of recurrence so that we can have those kind of conversations with the patient. But starting a DOAC up front, if the patient qualifies, no pregnancy, no mechanical valves, no antiphospholipid antibody syndrome, then we can, feel pretty confident about starting DOAC up front.
Yeah, we've done episodes. We did an episode with Jean Connors about like when to suspect or when it might be useful to do a hypercoagulable workup, and she's kind of the opinion that for a lot of the time it's not going to change what you do for the patient, especially for men. There's not really a way to make them low enough risk to say like you're not going to take it. But if they have family members, she was saying like a daughter that's going to become pregnant or is thinking about taking oral contraception, it might inform it in those cases if finding out that they have some sort of heritable risk factor. But in practice, I can say I see it done way more than I would like, and it rarely is changing things. Sometimes you're finding like a heterozygous factor 5 or something, and then people are just that helps. I guess some patients say, okay, they found something, I need to be on blood thinner for the rest of my life. What do you think? So
I think if you don't need to know, don't look. I think a lot of testing is done inappropriately. Like you said, over-testing is still running rampant. If someone has made it to 75, 80 years old and haven't had a blood clot, probably not thrombophilia is my first go-to for, checking to see what's going on. And, sometimes we test inappropriately. Like in the acute setting, you have a lot of inflammatory markers, things going on. So you can get false positives. People don't realize if they sent the test and they'd already given the first dose of DOAC, so you might get false positives. And, if you're getting a false positive, especially for antiphospholipid antibody syndrome, that lupus anticoagulant comes back positive, now we have to repeat it. And many patients don't get that follow-up in 12 weeks off of anticoagulation. And the biggest thing that, comes back to haunt the patient and, us in the clinic space is if you have a misdiagnosed thrombophilia, it does change your patient's approach to peri-op planning. So, when we have false positive APS patients that, were diagnosed 15 years ago and have just carried this diagnosis, and you look back through the notes and you're like, man, I don't think this was done. I can't find any follow-up labs. But now every time they go for any procedure, I have to bridge them. And now these patients the APSers are put on warfarin. So like you've taken pretty much like DOACs off the table for the majority of them, or at least definitely the triple positives. And there are still many people that won't even use them for single or double positive. But yeah, if they're on warfarin, now I always have to bridge them anytime they come off. It's very stressful if their INRs are high or low. So I think really shouldn't open up that can of worms unless you have young patient, multiple miscarriages, unusual clot site, like, renal artery thrombosis or CVST. And you're like, that seems strange. Maybe something else is going on here. But, most important is going to be the cancer, age-related screenings. So, someone's in their 40s, 50s, and making sure, did you get your mammograms? Are we screening for colon cancer? You get your PAPs done? Like the big things, like you don't look for the zebras. So that's kind of my stance on the thrombophilia testing. Unless it's going to make a difference, kind of leave it alone.
Well, Paul likes to do all the testing, so he doesn't like that, but I like that answer very much.
This is actually, no, I don't like this characterization, Matt. I think everyone knows that I don't like ordering tests where I don't know what to do with the results. So this is a domain where I don't go looking for trouble unless I am prepared to find it.
Yes, that is the bane of my existence. Can you try to explain to me how this positive test, I want it to be negative? So tell me that this is wrong. And I'm like, don't order
it. You just keep repeating the test until it comes back negative.
Yeah. And you said CVST, that's venous sinus thrombosis is what you were talking about with that. Okay. So that would be one of those sites of clotting where you're just like, maybe we should work this person up a little bit. Okay.
Not typical.
Mm-hmm. Yeah, I haven't seen that. You think about that, but in my line of work, I don't see it that often, certainly as a mostly outpatient doc, but I'm sure in your line of work, you probably see it more often than I do. I think we should get on to the next part of the case. So we treat Mr. Occlusion, but he returns for follow-up, and his symptoms have not gotten any better. Maybe even they've gotten worse, and the ultrasound shows DVT has persisted. So are we considering this a treatment failure?
That's a loaded question. I would want to know who read the scan. Ideally, I would like, one of our specialists to take a look at the baseline, like initial presentation, and then this repeat scan, make sure we're looking at the same angles. Sometimes it can just be residual clot that is there. I mean, the DOACs itself, they're not breaking down the clot. They're not lysis, so the clot's not going to go away. One of my favorite things to do is I work with the vascular and formerly NATF group and lead some of their patient support groups. And it's just interesting, to hear the patients, a month, 2 months, 3 months out, some of them still have pain and, or symptoms, and they get really nervous. But unfortunately, it can be fairly common, especially depending on where the clot is. I think this one was a fempop. If you start getting up into the iliofemoral, there's a high, chance that you might have, postthrombotic syndrome, So unfortunately, like those things aren't going to go away despite, changing anticoagulation. It's more so like symptom management and, compression, maybe seeing a vascular specialist to, make sure the valves are okay. But yeah, so I think it's a big thing is making sure that you are really comparing the scans so that if it's same or different, because most people, especially if they're taking their DOAC, fail. And then next in line, I'd be thinking about, adherence. Like, have you been missing doses? That's kind of the downside of the DOACs, right? The set it and forget it mentality. So there's really not a good way to know if someone's actually taking all of their doses. Did they take their Reveraban with a meal? Did they take both doses of their Apixaban every day for, the last few weeks? So kind of trying to suss that out a little bit. Sometimes if we're thinking in the moment, we'll get, a 10A level, just a surrogate marker to see if there's drug on board. You could potentially get a D-dimer. If it's very low, then it's likely the old clot, not a new clot. So trying to think through that way. So if they're subtherapeutic or non-adherent, then it's more so just getting them to be adherent or figuring out if we need to switch, like if it was a twice-a-day medication and they're like, I cannot do it with my job and lifestyle, then thinking about things that way, or getting them set up with like compliance calls or, apps or whatever it might be, or a touch base with the clinic. If they're on warfarin, assessing their INR, not just in that moment, but more so like long-term, like what is their time in therapeutic range? And then if you truly think it is a therapeutic failure and someone did read the scan and said, no, this is like new clot, or, clot was on the right and now it's on the left, that kind of thing, then we have to start thinking about, okay, do we need a new mechanism of action, like if they were on a DOAC or warfarin and seemingly therapeutic. This is where you get into the gray zone. Mark Carrier up in Canada had, put out a little guidance, a great guidance paper probably years ago at this point. But it's just kind of thinking through what we all think through is, okay, if, they're on an oral anticoagulant and, maybe the Lovenox dose was subtherapeutic, or they're on a DOAC, or they're on warfarin, you could potentially put them on a low molecular weight heparin for 4 weeks. If they were on therapeutic low molecular weight heparin, that's when you start to think about going up on a dose, maybe 20, 25%. But these are all like case-by-case scenarios. I think these treatment failures are kind of nebulous and hard to kind of pin down sometimes.
I think we have to call you if we get a treatment failure, it sounds like.
Can I put you on the spot here a little bit? Because you mentioned post-thrombotic syndrome, which I just feel like is something I don't hear discussed much, but I feel like happens a lot. Like, I don't know, can you give me like the 30,000-foot view of what that looks like? And is there anything, I guess, pharmacologically to do about it?
No, it's interesting because so the medical director of our clinic, she's a vascular medicine physician, and she actually is dedicated to our service like 2.5 days a week. So we work really closely talking about patient cases and going through this. And so she sees a lot of these cases where, they just continue to have this hyperpigmentation, discoloration of the skin, lots of reddening or edema. And it's not about changing the therapy. It's more so, managing the symptoms like the compression stockings and like medical grade, not like, order from online store, but getting a true fit in the clinic and, making sure they're like physical therapy, any other kind of symptom management for those patients, unfortunately, and tends to be higher in the patients that have, the clots that are higher up. So like those iliofemoral, which is probably why like when those present, they tend to think a little bit more aggressively of like, do we want to do catheter-based lysis or, extracting the clot, because we know that those patients tend to have higher rates of this like postthrombotic syndrome. I just think it's something that's not discussed a lot, but talking with the patients, especially in the support group, and then, talking with her, it definitely is prevalent and can be, very impactful to the patient's quality of life.
Yeah, I wonder if it's something like there's just higher pressures generated with that more proximal clot, and is there nerve damage from like ischemia, or who knows? But
right.
It seems like I've seen it a fair amount as well, Paul, and patients can be miserable, and the leg never, in some cases, the leg just never returns to looking normal.
Yeah, I think it's alarming and uncomfortable, and I think that you're right about the pathophys. I think this is sort of like an accelerated venous hypertension, like venous insufficiency as a result of the initial thrombus, and it's the patients can be deeply uncomfortable, which is why I wanted to ask. Thank you. That's actually really helpful.
And you mentioned is it old clot, is it new clot? I guess I never thought that much about it. I just thought like if you put people on it, that the body's natural fibrinolytic system or thrombolysis will take place and eventually the clot will go away. Because, sometimes, trainees will ask like, oh, do we get follow-up ultrasounds to see if the clot went away? And I'm like, usually no. Or sometimes patients ask that as well. Do you know of any places that are recommending like follow-up ultrasounds beyond like the distal DVT that we talked about where we're not treating them?
We usually don't, if it's not going to impact care. Like sometimes if, a patient is coming off of anticoagulation, then some people may get, a new baseline so that if something happens, weeks, months, years down the road, we know kind of where they were at versus, and sometimes even when we stop anticoagulation, there may just be like, residual clot that is just kind of adhered and didn't go away. But sometimes it can take months or, a year for some of the bigger clots to fully kind of absorb.
Okay. I wanted to ask, let's say, I don't think we gave you a BMI for Mr. Occlusion, but let's say he was 18 kg, or if he was, BMI less than 18, or if he was BMI greater than 40, 18 kg. Yeah. He's a pediatric patient. So BMI less than 18 or BMI greater than 40. So like kind of the extremes of BMI. Are we thinking any differently about DOACs? Like, is there more likely to fail or to bleed in those situations?
So with the patients with obesity, I think a lot has come out in the last few years. I know original guidance from ISTH said, recommend not using in patients with BMI greater than 40 or weight greater than 120 kilos. That's a large number of my patient population. So it was really hard to, have those kind of temporarily taken off the table for a while. But you realize that, the recommendation was more so based on positive evidence, because in, the large randomized controlled trials, they're getting the standard BMI patient. We're looking at weights of like 80 kilos, BMI like closer to like 28, 25. So it was more so don't use it because we don't know. And so I'm really thankful for curious people and, researchers that, look back at the data, see what we're doing with real world, and continue to track their own, prospective patients to look at the outcomes, because it's hard to take these drugs that do have a significant benefit in the population compared to warfarin and restrict them. So now we've really seen that, in patients with morbid obesity, these drugs behave fairly similar. Like the, therapeutic window is so wide. So, for many patients, they are going to end up with, a decent peak and trough to maintain therapeutic concentrations. So we are leaving these patients on DOACs. I think it's more so figuring out, again, where like the gray zone starts. So now it's really when we get up to those, weights of 150 kilos or BMI greater than 50, we have very few patients in that window. So that's more like the shared decision making of, what's your preference? Here are the risks. Here are the benefits. I'm not going to tell you we can't use it, but there may be a higher risk of treatment failure at those weights. But really, we are starting to, use DOACs and feel very comfortable and confident that the safety and efficacy is going to be okay. We actually had a case that was like a benign call of just someone saying, I have a monotherapy Fondaparinux patient, but I don't know what to do to, get them ready for surgery. So we said, okay, well, I talked to my medical director, see the patient in the clinic. And it turns out the patient had been on Fondaparinux for about 10 years and enoxaparin like 5 years before that. And it was for a clot that they had, and they were just, afraid to come off of anticoagulation. And then they told her, at the time that she wasn't a candidate for DOACs because she was 98 kilos and, BMI was, I think, 38. So, not only did we do the pre-op consult to, hold the Fondaparinux, but then the post-op follow-up where we said, hey, we may actually have something much better for you.
Immeasurably better. Oh my God.
Yeah.
Wow. Oh
So,
my gosh.
there's still a lot of education to be done out there, and you just got to keep, looking at every case, I think, and that's why I kind of love what I do, is because, it isn't set it and forget it. And by, re-looking back at patients, you can really make impactful outcomes. Like I know we are currently working on a project in our clinic where we're looking at patients on warfarin to see if they can be, DOAC candidates, because some of them have just been on it for like, 10, 15, 20 years. And when they came out, insurance didn't cover it. And so everyone just said, forget it. But now, that might have changed. And so we want to give people opportunities to succeed. And then with the low body weight patients, less data there, but still like, Apixaban is probably seemingly as, safe and effective as warfarin in this patient population, but just, being mindful that it's really not studied in these like, pediatric weights. And so, being careful there, but, Apixaban, not so much for VTE, but for AFib does have the criteria for dose reduction, if they're elderly and high serum creatinine plus that, factor in of low body weight, because we do know that it can increase risk of bleed, but not just for DOACs, like for warfarin too, like low body weight is a risk factor, So I think it's just more so changing, the mindset of warfarin isn't safer in these patients. It's just, people find safety in the monitoring of the INR, right? Like I have a lot of obese patients that were put on warfarin because it's safer because I can monitor it, but I can tell you that their TTRs are like not great. They have a lot of subtherapeutics or critical. So just because you can monitor something doesn't necessarily mean it's safer for the patient.
I was just going to raise the point, this idea of transitioning people off warfarin when possible is just so appealing, just because I feel like people don't have comfort with warfarin anymore. Maybe they have comfort like knowing that you have the INRs to monitor, but I just don't think, it's just not as commonly taught skill set as it was when Matt and I were in residency and we were doing back to the cocktail napkin calculations about warfarin dose increases. Like, I just don't think people, I hate to be like the kids these days, but I think because we have newer, better agents that don't require monitoring, there's just we're not doing these dose adjustments as much as we used to. And I don't think people quite know how to do it well. So I think it just feels less safe no matter how, to me, just because of the lack of comfort, not because of any intrinsic qualities to the medicine itself.
No, I agree. We have a decent patient population. Our clinic right now between warfarin and DOAC has about 5,000 patients. But I know that in our health system, there are so many patients still being managed by their local PCP offices. So we're kind of working on a central anticoagulation management program that I call CAMP. And I love it. But, so we want all the patients to come to camp, right? Because what we know is they have more fun with us. And we have counselors ready to screen them and get them on the, appropriate therapy. But sometimes when we inherit these patients from primary care, it can be eye-opening. Sometimes patients are lucky if they get one INR a month. And then when we call them back with their dosing, they say, oh, you called me. Sometimes if I don't hear back, I just adjust myself. And it's like, okay. So just trying to figure out, or, the dosing patterns, they're not standardized. Sometimes it depends on who, answers the call, and it's a boost or a hold or, multiple doses of warfarin instead of just one tablet strength. So we try to do a lot of stewardship when we inherit these patients and flip them whenever we can.
God, there's the old tortured doses of all right, you'll take 3 milligrams Mondays and Tuesdays and 2.5 milligrams Thursdays and Saturdays. And then on Sundays, I don't know what to tell you. Just skip it.
Hold it.
They're insane.
Okay, you mentioned, I have to bring it up because you mentioned it a couple times, monitoring INRs. What about this 10A? You mentioned peaks and troughs. Is anyone using that? I haven't seen it done too often, but in what situations would you check a 10A level?
So we don't have, the DOAC specific assays in our hospital. So sometimes we'll get a surrogate marker, to just do a quick and dirty, is the patient on drug or not, can be helpful, if we need to reverse prior to surgery, or if you're checking efficacy, if someone came in with had previously had a DVT and now presents to the ED with an acute PE, and I have to start, a parental agent, just to see if the DOAC's even on board at the time, and if that was a treatment failure or just, lack of treatment. But I do think, another caveat to the obese population are, the patients that have had, gastric bypass and surgery. Anytime you're altering the gut absorption, cutting around in there, the drugs may not be absorbed as well. They're absorbed in the stomach and the lining of the intestines. So sometimes in those cases, it may be worth if you could order a drug-specific level to make sure that the patient is absorbing drug. I know that ISTH guidance, came out and recently said, acutely after bariatric surgery, you should not be using, the DOACs, but, for long-term maintenance may be okay. So I think it's trying to figure out if, your patient is going to be successful or not. That's where I would see it could be helpful. Looking at a couple of poster presentations I've seen on mostly in the UK and globally where they're having these levels available, there is variability in the gastric bypass patient population. So they tend to do a little bit better with Edoxaban compared to Debigatran or Reveraban. But and just like with everything, right? Not all patients are going to succeed treatment, but there may be more room for failure in those patients.
And you said there are specific 10A levels, so there's a specific test for Edoxaban versus Reveraban. Is that what you mean by that?
Yeah, they have chromogenic drug levels that you can send. But for us, if we send them, it's rare that I'll ever get it within a week. It's usually 5 to 7 days turnaround. So in an acute setting, it's not the best, but it's something that we have used in these potential patients where we are worried about drug absorption.
Mm-hmm. So to go back to this variation on the case, we said, let's say that, just to make it very clear cut, our guy, Mr. Occlusion, he first had a clot in his right leg. He came back with a new femoral clot in his left leg, and he was taking his medication. So what would most people do if he was initially put on a DOAC? Like, let's say he was taking Apixaban 5 milligrams and he took it correctly as far as we can tell. Are people going to switch him to low molecular weight heparin, or are they going to switch him to Debigatran, since it's a direct thrombin, not a 10A, warfarin? What would most people do there?
Yeah, I mean, I think you nailed it right on the head. Like, I think first grab is usually the parental, so low molecular weight heparin. While we get things settled out, could potentially look at the Debigatran if the patient was a good candidate. But again, also considering the bleed risks with that as well. But those are kind of the two upfront options. Probably at least like Lovenox for at least like 4 weeks.
Mm-hmm. So 4 weeks, you're saying like enoxaparin, and then you would maybe move him to Debigatran.
So I think it would depend, because if they were like, stone cold solid, taking their DOAC twice a day, no missed doses, then you start to wonder, is something else going on? Was there kind of a major risk factor that I'm missing? Like, do they have cancer? Start asking questions like, have you been, any, recent major weight loss, any kind of chills, fever, things like that. Cancer-related screenings, that's when you might start thinking about, a thrombophilia if, they broke through therapeutic anticoagulation. So I think the kind of first month gives you a chance to kind of figure out what's going on, and then, think about long-term therapy from there. If it's, it did turn out to be APLS, then it's going to be like a transition to warfarin versus a DOAC, those kind of things.
Yeah, I think I'm probably going to get you involved at that point, Tara. If we had an anticoagulation pharmacist where I worked, Paul, this is a time you would refer, right, or at least call a friend for help.
This would be at a minimum a phone call with a pharmacist or hematologist, or possibly both. Yeah.
Mm-hmm.
Yeah, you can get like a baseline coag, see where they're at. I mean, most of them shouldn't be impacted by the DOAC, but if they had like a very high APTT, like baseline, greater than 40, you might start to think about some, thrombophilia in that patient as well. So there's kind of some little tips and tricks you can do to help when the hematologist or, vascular med doc comes on board and starts doing the workup.
All right, Tara, let's go back to Mr. Occlusion. So rarely, Matt, do we have something awful happen to our patients before they come and see this. But let's say Mr. Occlusion shows up in the emergency department. He's reporting lightheadedness, dizziness. He's feeling kind of crummy and weak and tired. He's also reporting black stools, and it turns out that he's probably having an acute GI bleed. His hemoglobin comes back, and we'll say it's in the toilet like 6 and change. Let's make things scary for him. I feel like with the newer agents, the idea of reversal comes up a lot, and it's whether you want to address Mr. Occlusion's tragic case or sort of talk more broadly about reversal agents and options that we have available for the DOACs. I would love to hear your take and sort of what the state of the art is right now.
Yeah, this is a topic that's actually been, a little spicy lately, trying to figure out what to do with the DOAC reversal, what's, best in class. Historically, we've had 4-factor PCC for reversal, and, then the DOACs had the specific Edoxaban alpha that came to market. I think a lot of sites had adopted it and used it first line for DOAC reversal, but the data has kind of come into question. There was actually recent FDA hearings that went on looking at Edoxaban, and I believe where they kind of left it was the FDA is asking for, some more data to kind of be able to give it full approval. So I know some sites, even in my own health system that were previously using Edoxa, have taken it off formulary and are going with 4-factor PCC for reversal of these patients. And then, just kind of there is the quagmire of is it 25 units per kilo or 50 units per kilo. Usually we'll do 25 units per kilo for, extracranial bleeds. And then if it's an intracranial, I think the neurocritical care guidelines suggest closer to 50 units per kilo, or some sites will still do fixed dosing, 2,000-3,000 units of 4-factor PCC. And if you have, Indexa, then it's based more so on the drug that you took, whether it's Apixaban or Reveraban, and the dose, whether it's high or low, and the timing.
I like describing it as spicy. You can just tell that you really that you're really deep in this world. That's like a spicy.
What's the hot goss with
That's the hot goss
coagulation?
on it. And
That's the tea.
I'm not like honestly like we're simpatico with you. I'm saying like that's this internal medicine. This is our world.
Right.
Is it that they're worried it doesn't work, or is it adverse events? Why the questioning?
So, unfortunately, they see more thrombotic events after administration. So it's the safety that we worry about. So we're, trying to reverse the bleed, but then patients are having an increase in thrombotic events, specifically stroke. Not great, especially because the majority of the VTE patients, thankfully, the safety profile is pretty good, right? And when we think about our VTE patients, like we have some, 80, 90-year-old patients, but the majority are getting their first DVT in their, 40s, 50s, 60s range. So when you have these, frail AFib patients that are on, these high doses of DOAC and they bleed, it's not good. And they have a lot of, morbidity associated with that. And then, if you're treating someone for their bleed and then they have a stroke on top of it or a new DVT or a PE, that's not great. Also, I know for some of the surgical populations, they would see some heparin resistance after giving andexanet too. So if you were to give it in the ED and then the patient had to be taken for surgery or, they needed to give any heparin, for bypass or something like that, if they were just reversing so they could take the patient to the OR, that could be problematic as well. So those kind of things I think give people pause. It's not that 4-factor PCC is great. When you're, having a major bleed, we know already the morbidity, mortality rates are high. But if we're going to further complicate that with a new thrombotic event on top of, the bleeding event, we want to try to avoid that when possible. So I think, they have a window now to present new data. But until that is done, I think there's been a lot less use in all populations, intracranial, extracranial.
Wow. That is okay.
You heard it here, folks.
Yeah. Well, listen, we've talked about a lot tonight. We've talked about initial choice of anticoagulation. We've talked about drug interactions. We've talked about what to do with distal DVT and or not to do with distal DVT, I should say, and then what to do when someone, seemingly fails anticoagulation. Definitely learned a ton. So thank you so much. But what would you like to remind the audience about? What are your main take-home points?
So I think the main take-home points are, treat every patient like an individual. These events are big and scary for them. So if they don't feel heard and seen, then they don't take their medication and then they have, more complications, more problems. I think it's always not having the set it and forget it more mentality. We still find a lot of patients in our clinic that we don't discover till they need a pre-op eval. And we're like, why are you even still on anticoagulation? Your eval is that you should stop anticoagulation 5 years ago. Just continuing to educate yourself on the guidelines that are coming out and empower your patient to, have a successful, course of treatment.
All right. And would you like to plug anything? Maybe a forum that you're part of, or?
Oh yeah, I just got newly inducted. I'm now a board member of Anticoagulation Forum, so I'm so excited. That's kind of like a big life goal, life event for me. But it's a wonderful organization dedicated to, making resources readily available for, pharmacists, providers, to take to educate themselves to, treat their patients. We recently just put out a rapid resource, so an easy go-to for how to manage anticoagulation in menstruating patients. We also put out a great one on peri-op management of anticoagulation. So I definitely recommend checking it out. And then I also do some work with Vascular, formerly NATF, and that's a really great patient-focused group where they are dedicated to making resources for patients, to kind of help them through the transition in this journey. So they do patient support groups. We recently put together a patient version of, the chest guidelines so that they know what questions to ask their provider when they're going for a procedure. So I think using your resources, knowing what's out there. But yeah, those are two organizations that are near and dear to my heart. I can leave you with a joke.
Oh, yeah, please.
All right. So why aren't there any fairies in the anticoagulation clinic?
Paul,
because we had a pixie ban. Oh, come on, Paul, man. All right. So
he's good at guessing.
So good.
Them.
Yeah. I could see it. That's why I was trying to say it. I was like, oh, he knows. He's just going to.
Paul, you had to spoil it, Paul.
Right? I'm the worst. I know. This is well established. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy?
Yummy indeed. Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge. And to do that, we need your feedback, so please email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. And a special thanks to our writer and producer for this episode, Ben Furman, and to our whole Curbsiders team. Our technical production is done by the team at Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chumenchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, our main Dr. Paul Nelson Williams, thank you and goodbye.